Okay, I think I'll go ahead and get started. So I know that I know many of you, but for those of you I don't, my name is Brittany Garcia, and I'm one of the hand and upper researchers here at the University of Utah. And today we're going to talk about a topic that I think affects all of us, which is peripheral nerve injuries and orthopedic surgery. We're going to focus specifically on the evaluation and management. I have no relevant disclosures. So I was asked to talk today about something that's a clinical interest of mine. And so I thought I would do a little bit about the background of myself. I did a hand and upper extremity fellowship where we did bread and butter hand surgery as well as the management of nerve, including both nerve injury as well as neuronal management. And then I did a congenital upper limb fellowship where my passion really lies, and that included some work in pediatric brachial plexus birth injury, which is sort of what amplified my interest in nerve surgery. And I think that this is a really interesting area because it's a ripe area for improvement. We've learned a whole bunch over the last couple of decades, and there's still a lot more for us to be able to improve patient outcomes in this arena. So just an outline of our talk today, I'm going to talk to you about what is the relevance of this topic for the current audience. We're going to talk about the basics of a nerve cell and a nerve. We're going to talk about nerve injury and how you evaluate a patient who has a nerve injury. We're going to talk about how nerves recover, how we repair them, and when we can't repair them, how we reconstruct them. And because we don't have awesome options, we don't have awesome outcomes for repairs and reconstruction, and we've got lots of other things we think about, such as nerve transfers, tendon transfers, and then we're going to touch just very briefly at the end on neuronal management. So how about the relevance of this topic for you? We're going to focus on two broad areas. So we're going to talk about traumatic nerve injuries, and then we're going to talk about iatrogenic nerve injuries. I want you to remember, though, that there's lots of other reasons you can have nerve injuries. So you can have caustic nerve injury, you can have chronic compressive type nerve injuries, but today we're going to focus on trauma. So when we look at trauma patients, trauma and iatrogenic, when we look at trauma patients, we see that there are 200,000 polytrauma patients a year that have a peripheral nerve injury. So that amounts to about 5% of all trauma cases that are coming into our facilities. And when you think about a patient who has a peripheral nerve injury, they have many things that are important for us to consider. So you may do a really, really nice surgery, but the patient continues to have chronic pain. It affects their quality of life, and it also causes significant psychological as well as functional disability. When you look at patients who have a peripheral nerve injury, we're starting to look at ways to evaluate these patients and what their outcomes are. And this was a nice study that was published pretty recently in the journal Hand Surgery that looked at 84 patients with peripheral nerve injuries, and said essentially when you look at their SF-36 scores that these patients have much lower health status as well as significant long-term disability. So this is definitely a patient issue. But what this is also is this is a physician issue. So for us, when you have a patient that comes in, you feel like you've done a really nice surgery, your x-rays look anatomic and you're really happy with it, the patient may still have pain. And so, you know, Dr. Dariush may have repaired their ulnar collateral really nicely, but they're like, I have pain here. I have pain here. And they don't care how stable their thumb is. All they care about is that they have pain here. So it can be really distressing for us, and we follow these patients over a long period of time, and we have sort of a mixed bag of things that we can do for these patients. And then there's also the legal implications of peripheral nerve injuries. So when I was thinking about how to present the relevance of this topic to you, I decided I would look at our subspecialty journals, so journal Hand Surgery, foot and ankle, JSES, and just sort of see what's been written on peripheral nerve injuries in each of our subspecialties in the past couple of years. So in the upper extremity, we think about things like the medial antebrachial cutaneous nerve in the setting of the cubital tunnel. In elbow arthroscopy, we see rates between 14 and 30% peripheral nerve injuries with an elbow arthroscopy, which you should think that's sort of an elective type procedure. Axillary nerve is really important in shoulder surgery, arthroscopy, as well as arthroplasty. And then the radial nerve is something we think a lot about, not only just when a patient presents acutely with a Holstein-Lewis type fracture pattern, but when we're doing non-union repairs of those, the rate of radial nerve injury can go up significantly. So I thought this was a really interesting article and is very timely for this topic. It's in preprint in the journal Shoulder and Elbow. And essentially what it looks at is how common is a nerve injury after a reversed total shoulder arthroplasty. And so if you start to break it down, you see that incidence in the systematic review of 40,000 patients is only 1.3%. So you're having a conversation with the patient preoperatively, and you're telling them, here's my conversation about risks. You have about a 1% chance of getting a nerve injury. But when you start to break these patients down, you start to see that in the cuff tear arthropathy patients, the risk actually increases quite a bit. So it's 3%. And then when you start to look at proximal humerus fractures and you're doing a reverse for that, the rate increases to 4%. And I think that your conversation really changes. When you go from telling a patient you have about a 1% chance or less than 1% chance that you're going to have a nerve injury with this surgery, to saying you have close to a 5% chance of having a nerve injury with this surgery. I think that's something that you really want to make sure that you're talking to your patients about preoperatively, and that you understand that if you have a patient who has one of these injuries, you kind of have some resources to be able to solve that. So how about the lower extremity? Travis Mack wrote this really nice article that was published in JBJS that reviews all sports-related peripheral nerve injuries. It's fairly recent, which is sort of talks to you about the importance of the topic for us. It has things like the superficial perineal nerve, which we know is problematic in ankle scopes, the saphenous, anterior branch of the saphenous nerve, which can affect both total knee arthroplasty as well as ACL surgery. The common perineal nerve, we have multiple studies that show that there are rates of common perineal nerve injury after a total knee arthroplasty up to about 4%. Similar with the sciatic nerve and total hip arthroplasty. And then I thought this was kind of interesting. When you look at the bigger studies done on revision, total hip arthroplasty, you see that from a posterior approach, your rate of a sciatic nerve injury increases significantly, so almost 8%. I wanted to bring up the LFCN because I think that this nerve is a equal opportunity player, so it affects our traumatologists when they're doing an ilioinguinal approach for pelvic fractures. It affects our hip arthroscopists when they're doing an anterior portal. It affects our arthroplasty surgeons when they're doing a direct anterior hip. And the thing that I thought was kind of annoying about this nerve is it even affects our shoulder and elbow fronts. So when you have a patient positioned in a beach chair position, I've heard Taj when I was a resident be like, you've got to pat this area, you've got to have not too much flexion at their hip. So you start to realize that small things like this can be a problem for you. So what now? So I think that there's been a wave of publishing literature on what are the common injuries in each subspecialty. And now there's this wave of saying, what do we do about these injuries? So you have papers like this coming out saying, well, we know that this is a problem, the patients get common perineal nerve palsies. How do we predict who's going to get better and who's not going to get better? And then papers like this out of the Journal of Arthroplasty, which say, how do we have things that we can add to these patients with nerve injuries that can make them get better faster? So for example, the second article is looking at nerve decompressions following sciatic nerve injuries and total hips. And then what are the patient's perceptions? So how are patients perceiving nerve injuries? How do they think about them preoperatively? And how do we counsel patients about them? So we're going to talk just a little bit about nerve anatomy, because I think that understanding the building blocks of the nerve sort of help us predict how a nerve's going to recover and what our options are for reconstruction. So the basic nerve cell is a neuron. The neuron contains, the neuron is the nerve cell that has electrical excitability. And these neurons live in the peripheral nervous system in two different areas: anterior horn cells, where your motor nerves live, and the dorsal root ganglion, where your sensory nerves live. And it's made up of a couple of things: the cell body, which contains the nucleus; the dendrites, which are these projections around the cell body, which are the things that receive the signals; and then a single axon, which you're going to spend a little bit of time on the next slide. And these communicate through this area called the synapse, with things like myocyte at the outer end plate. So thinking about axon specifically, this is important when we talk about nerve recovery. So understanding the axon is imperative. It's this long, slender projection that comes out of the nerve cell body. It's covered by myelin, which is produced by glial cells. And that myelin is sort of an insulating type material that allows for the conduction of your action potential along the length of your axon. And you put a bundle of axons together, which are typically either motor or sensory, and that makes up a fascicle. So looking at basic peripheral nerve anatomy, the smallest unit is the axon. a group, which is what the internurium surrounds around a group of axons is the perineurium, and this makes up a vesicle. And the perineurium is important for a couple of reasons, because it's the largest sort of visually, grossly visual unit that we can identify. So you can see a vesicle nerve, we can't see anything more granular than that. It's also important because this is where the vascular supply lives, and this is where the nerve gets some of its tensile strength as well as its elasticity, so it makes it a little bit more resilient. And then the epineurium, which surrounds a group of vascicles, and is the outermost layer and also has some blood supply. This concept is important. So nerves have a dedicated topography. And the reason that's important is because if you start to do nerve repair and you start to repair motor fascicles to sensory fascicles or vice versa, then you're not going to have very great outcomes. So essentially, what you see when you cut the end of the nerve is you're going to see a bunch of fascicles. And you need to understand the topography of your nerve that you're repairing in order to be able to do a good repair. So for example, if you look at the ulnar nerve in the proximal form, there's three large groups of fascicles. There's a dorsal sensory, there's a motor component, and then there's another sensory component, which goes to the volar hand. If you're repairing the nerve, the ulnar nerve here, it's very different than the alignment that you're matching up down here at the distal forearm. So it's important to know that, so that when you reconstruct them, you're correcting those fascicles in the correct orientation. So how about nerve injury? Let's talk about a little bit of basics. The peripheral nerve system is different than the central nervous system. And the reason why is because it has the ability to regenerate, which is good for us in some ways. The recovery is determined by a lot of things. So where is the injury with respect to the cell body? What type of injury is it? Is it a complete transection? Is it a crush injury? Is it a neuropraxic injury? What is the age of the patient? We know that younger people typically do better when you're doing nerve repairs. And what is the mechanism of injury or type of energy? And we know that when you injure a nerve, that you lose the function of the nerve in a predictable pattern, starting first with motor, and then you progress to touch, pain, and then your sympathetics. And when you repair nerve, you're looking for recovery in the opposite direction. So you're looking for these signs early on after nerve repair to see if your nerve is regenerating. So what's the deal with the axons? So the deal with the axons is that axons are these long projections, with your sciatic nerve being the longest one in your body. You can imagine the cell body of your sciatic nerve is originating way up here in your lumbar spine. It's going all the way to the tip of your toes. So if you injure your sciatic nerve way up here, it's going to take a long time for those signals to get back to the motor implants in your lower leg. So it's sort of like saying your cell body lives here. Your cell body lives here at the University of Utah. Wait for it. Your cell body lives here at the University of Utah, and your myocyte lives here in New York City. And you're going to sort of block the road or block the axon here in Denver, and then you're going to fix it. And then you're going to walk from Denver all the way to New York, and you're going to hope by the time that you get to New York that there's still something left to innervate. And that's the concept with nerve repair, and that's why nerves are peripheral nerve injuries can be frustrating for us, and why there's been so much written on it about how do we make these better. So let's talk about how we classify nerve injuries. So Seddon classified these injuries back in the 1940s into three major groups. There's neuropraxic injuries. These are some of the most common that we see in our practices. There's axonotmetic, and then there's neuroptomesis. And neuroptomesis is essentially synonymous with a complete transection injury. And then Sutherland came in the 1950s and he said, we need a little bit more granularity to this classification so that we can help predict how these nerves are going to recover. And so he broke these down into 5 different degrees. And then Susan McKenna, who is kind of pioneer in the nerve world, added a 6th degree. We're going to go through these in a little bit more detail, but in general, the histopathology changes as you get an increasing severity of nerve injuries. So what does that mean? That means that when you have a neuropraxic injury, all you have injury to is myelin. As you get worsening injury, so a neuroptomesis or a transection, you can see that the connective tissues are progressively injured. And that has obvious implications in how these patients are going to recover. So let's start with neuropraxic injuries. So Neuropraxic injuries or first-degree injuries are ischemic type injuries or stretch type injuries. And we see this in our world in things like tourniquet palsies, foot drop, following traction for perineal nerve pressure. And essentially the key to this is that the myelin is gone. So if you look at the nerve cell here, you see that there's no myelin. So you know that that's going to affect your conduction velocity. The nice thing about neuropraxic injuries, is that's commonly what we see in orthopedics when we have an iatrogenic injury. And the other thing that's nice is that all you need to do is regenerate your myelin. So these nerve injuries recover quite nicely. And we usually can tell patients that they're going to get complete recovery of their injury in up to about 12 weeks. So axon-and-tematic injuries. So pay attention here. So first, the myelin is out, neuropraxic. Now axon-and-tematic means that you have an injury to your axon itself. There are varying degrees of injury to axons. So you have a spectrum from second to fourth degree injury. Second degree injuries behave very similarly to neuropraxic injuries. So those patients, you have intact endoneurium, perineurium, and epineurium, but your axon is disrupted and needs to regenerate. And these patients you expect to have complete recovery, which you could follow on EMG by looking at their motor unit action potentials. And you can follow these patients with a Tinel sign. Tinel sign goes with axon-and-tematic injuries. Neuropraxic injuries don't have those. And you can usually tell patients they're going to get complete recovery, but these are going to recover a little bit slower than your typical neuropraxic injuries. So how about third degree injuries? So this is where things get a little bit dicey. You start to get some endoneurial fibrosis, and these are a little bit less predictable because you get increasing injury to the supportive connective tissues. And so what happens in a third degree injury is you get axons that don't always go through the injured section to their target area. And so the expected recovery we know for patients who have a third degree injury is typically better than if we reconstruct those patients. So if you've got, an injured nerve and you're getting some axons across it, that's typically better than if we resect that injured area and we put a nerve graft in that area or reconstruct it. These are the patients we think about things like babysitter nerve transfers. So for example, if you have a high ulnar nerve palsy, it's going to take a long time to reinnervate the intrinsics of the hand. So sometimes we'll do a nerve transfer that's closer to the motor implate to allow these motor implates to get reinnervated quicker. And then fourth degree injury is very similar to neurotematic or transection injury. The difference is that this is basically neuroma and continuity. So you've got a segment of healthy nerve, a neuroma, and a segment of healthy nerve. And through the neuroma, you don't have any good signals that can get to your end target. These patients need surgery, such as excising that neuroma and grafting it with auto or allograft. Okay, how about the fifth degree injury? So this is the patient who has a complete transection. So we've all seen the intoxicated person who's punched through something glass and they come out with a large laceration to their upper extremity and they have no sensory motor function or particular distribution. That's these patients. And the reason why this is so bad is because there's no connective tissue. There's no axon there's no connective tissue. And these patients, similar to the fourth degree patients, will not recover without surgery. So what happens to the peripheral nerve when you injure it? We're talking about not neuropraxic injuries here, but basically axon-and-tematic and increase in severity. So in the proximal stump, the axons retract and they start to undergo this dormant phase and they start to secrete neurotropic factors. In the distal stump, you get Wallerian degeneration. So again, axon injury, Wallerian degeneration, Tinel sign. And you get degradation of those neural elements. They start to be phagocytosed, and then your Schwann cells start to turn into this sort of pro-regenerative phenotype. So nerve regeneration. We'll talk a little bit about the physiology. I think that this is a really interesting slide because this sort of tells me why are we doing the things we're doing in terms of trying to make the motor implates innervated quicker. So we know that muscle, we can see some viable muscle cells between 18 and 24 months. That doesn't mean that you should be waiting 18 months before you start reinnervating those muscles. The reason why is because you start to get significant muscle atrophy as well as fibrosis very early. You start to see a decrease in muscle volume. You get increased motor implates, which is what causes increased sensitivity and fibrillations on your electrodiagnostic studies. And then by 12 months, a majority of the motor implants are already degenerated. In the first month, you get about 30% muscle atrophy. So 1 month with the muscle being completely denervated, you get 30% atrophy. By the time you get to 2 months, it's 50 to 60%. And by the time you get to 4 months, it's 60 to 80%. And this is why when you've got a complete transection injury, you need to repair the nerve early. This is also why if you don't know what kind of nerve injury you have, you need to be working it up expediently. When it comes to sensory, these are interesting because these can hang around for a long time. We've got 3 major sensory organ types, which are your Meissner's corpuscle, your ruthenium corpuscle, and your Merkel cells. And these potentially can survive for several years, but there's a debate on what the longevity is for reinnervating a sensory organ. What I think is probably generally accepted in our community is that if you repair a nerve, a sensory nerve pure sensory in less than 6 months, that you can probably expect to get some discriminatory sensation back. But after 6 months, you're hoping probably at best for just some protective sensation. So if you touch something, it's hot, you know it's hot. And this is a nice table that summarizes that. So it says, when you go from a neuropraxic injury to a neurotometic injury, what are the things that you're looking for in terms of physical exam? How do you counsel the patient to how quickly they're going to recover? And then how do we know which of these patients are going to end up needing surgery? So understanding what kind of peripheral nerve injury you have is important for knowing what to do next with your patients. So then how do we evaluate a patient with a peripheral nerve injury? I group this into 3 large categories. The first is physical exam. I think the physical exam is probably the most important part of evaluating a patient with a peripheral nerve injury. It gives you good pre-test sort of probability for any of your other types of studies that you're getting. We have various imaging modalities, which we'll talk about. And then I think on the bottom of the list is electrodiagnostic studies. So obviously observing the patient, looking for atrophy, things like that in chronic setting can be helpful. But when you're evaluating an acute nerve injury, there's lots of different ways you can evaluate sensory. The 3 that are highlighted here are sort of what I do in my clinic. So when a patient comes in, they get a light touch test, or what's called a TEN test, which has been validated. And essentially, you just ask the patient on their involved and uninvolved side, if perfect is 10 out of 10, how would you rate your sensation of the scan? And then I do a threshold test. I think this is helpful and more sensitive, particularly in compressive neuropathies, and that's a monofilament test. And then I do an innervation density test, which is a 2-point discrimination. When we look at nerve recovery, we have the MRC grading system, which helps us to sort of follow a patient over time. So having a really good baseline exam is important so that each successive visit, you can say, okay, yeah, I see that you're meeting these milestones in this way. And we grade motor recovery from the top, an M0, no contraction, to full muscle strength at M5. And sensory, similarly, no recovery at S0 to an S4, which is complete recovery. And as you get down this list, you get improvement in your 2-point discrimination. And I think it's important to note that physical exam can be very basic and should be very basic in a lot of ways. But then when we have specific nerve type injuries, we have specific exams that can be helpful and have been validated for those populations. So one of my clinical interests, as I mentioned, is brachial plexus birth injuries. And in these patients, we rely heavily on the physical exam because we can't get an EMG. They have an immature peripheral nervous system. MRIs, you have to sedate a baby. We really try to avoid that. It has long acquisition times. And CT scans in this population can be poor for identifying postganglionic injuries. So we do this, the patient comes out 1 month of age or earlier than 1 month, and every month we see them after that to look for neurologic recovery to be able to predict what we need to do with them from a non-operative or a surgical standpoint. So let's start with imaging. I wanted to mention just briefly that radiographs in our world are very important. So I think injury pattern on your radiographs can be helpful for particularly predicting your peripheral nerve injury. I also think if you're proceeding with reconstructive options, then you want to make sure you have a stable soft tissue envelope as well as fracture healing. And I think it's pretty common for us to have radiographs in our patient population. So how about MRI? So MRI is really good for looking at nerve injuries in specific settings. It's not operator dependent. And the nice thing about an MRI is you can evaluate a nerve in a long segment. So you can evaluate a large portion of the nerve. And it also can help you evaluate muscle characteristics. So if you're looking at fatty atrophy or edema from denervation, it can help you with some of those things. This is a patient of mine who had an idiopathic PIN palsy. So radial nerve, you could see, was working okay, but the PIN was not working okay. And so she came in with no known injury. So one of the things we think about for this is, does she have some sort of compressive lesion on her PIN nerve? And this is a perfect situation where an MRI is nice for that. The disadvantages of an MRI is that it's costly. It's not a point of care study, so it can sometimes delay your decision making, and it can be time consuming. And then the thing that I think is most important for us when you're thinking about, should I order an MRI on my patient or not, is we have a lot of things that come into play when we're thinking about imaging. So for example, you've got hardware in there that's going to cause some scatter. You can have hemorrhage or edema, which can alter your ability to be able to really look at your nerve injury. How about ultrasound? So I really like ultrasound. It's becoming really popular in the hand and upper extremity world. I think that you can do a lot with ultrasound in clinic. It's non-invasive, it's point of care, so it's very quick. All patients who have carpal tunnel get an ultrasound in my clinic, and that's largely replaced getting electrodiagnostic studies. The key is it's operator dependent, right? So it's similar to electrodiagnostic studies where it's only as good as the person who's doing it. And that it's got some limitations when it comes to depth. So when you start to get greater than 3 centimeters or you have a large soft tissue envelope, it becomes a little bit less sensitive for looking at these injuries. But even Dr. Short can do that. Okay, so let's talk about electrodiagnostic studies. Electrodiagnostic studies evaluate the physiologic state of the nerve. So they help us characterize the location, how long the nerve injury has been going on, and if there's any healing. And we've got 2 major groups for this. We've got your electromyography, which is EMG, and your nerve conduction studies. And when you're ordering these, you should always order them together because the combination of them is much better than either one in isolation. So let's start with nerve conduction studies. They evaluate the integrity of the axon and the myelin. So they're looking at the conduction across your axon. So if you've got injury to your axon, obviously there's going to be some changes. If you've got a neuroplastic injury, you've got decreased velocity, then there's going to be some changes from that standpoint. And essentially what you do is you stimulate a peripheral nerve, and then you record your response elsewhere. So it looks like this. You place a active electrode over a muscle belly, like your APB, and then you place an inactive electrode distally, and then essentially you stimulate that and you look for the compound muscle action potential. So when you get your electrodiagnostic studies, you get the sheet back, there's all these boxes, there's all these numbers, and you're like, what do I need to pay attention to? What am I looking for? And so in your nerve conduction studies, you're looking for compound muscle action potentials. And that gives you, that breaks down into the latency, the amplitude, and the velocity. So how fast is that signal traveling? And similarly, in a sensory nerve distribution, you can see this is a digital nerve distribution, and then it produces the sensory nerve action potential. So how about EMGs? So they evaluate the resting potential as well as the contracting muscle electrical activity. Breaking it down, trying to make it very simple. What are you looking for when you're looking at an EMG? A couple of things I look for in a patient who has an EMG comes to my clinic. The first is polyphasics. So if this is a patient with a peripheral nerve injury, and then they've gotten an EMG, they're several months out from injury, polyphasics are good. Polyphasics tell you that the nerve is recovering and that the muscles are starting to get innervation. What you don't want to see is fibrillations or positive sharp waves. Fibrillations are synonymous with denervation, so that's a poor prognostic factor. So you're going to look at your EMG, you're going to say, do I have polyphasic fasciculation? Fibrillation. Fasciculations are more of a central nervous system finding. The important thing is that EMG does not always correlate with cardiac recovery, and that's why I say you really have to depend on your physical exam first, and then use electrodiagnostic studies as a confirmatory test. The other thing that's really problematic about electrodiagnostic studies is they are very operator dependent. So depending on the person who does it, it can be good or it can be bad. It's temperature dependent. It depends on how precisely you're putting your electrodes over the injury or nerve of interest. And it can be problematic when you're trying to evaluate deep structures. So cervical type pathology or brachial plexus, again, requires pretty specific electrode placement and experience. And then, like I've mentioned a couple times, it really depends on what your pretest probability is. So this should not be like confusing nerve patient in your clinic that you're like, I don't really know what's going on, we're going to nerve study. This is going to say, I'm concerned that we have a nerve injury. I'm concerned that it's like, you know, a second or third degree injury, and I want to know if this patient is having any recovery. And then you get an electrodiagnostic study to confirm that. The key is this can be normal in the first days to weeks after a nerve injury. So you don't want to just shotgun get these studies when you're like nervous about a nerve injury. So I think there's this sort of division when we look at using electrodiagnostic studies to predict nerve recovery. There is the first through third degree injuries, and the things again you're looking for are motor unit action potentials. Those are telling you, yes, in the chronic setting, this is telling me that I'm getting some of these and that my nerve is recovering. If you don't see any motor unit action potentials, then you're getting really worried. You're saying this might be a neuromotor continuity, this might be a transected nerve, and this is something that I need to do something about. So what I would say is I would not hang your hat on electrodiagnostic studies. I think that you have to use that in combination with your physical exam. I would say if you're worried about, if you suspect that you've got a first or second degree injury, it's one of those that are more similar to a neuropraxic injury, which is a lot of what we see, I would say do a good exam and observe the patient. You don't have to get an electrodiagnostic study. If you really want to get one, it makes you feel better, the patient would like one, I would wait a minimum of 3 to 4 weeks. And the reason you need to wait for that is because you need to wait for Wallerian degeneration to start, and you need to wait for the signs that show you that you've got some recovery of your muscle. Because if you get it in the first 2 weeks, you have no idea whether or not that this is a muscle or an injury that's going to recover. If you suspect that you've got a fourth or fifth degree injury, so neuromotor continuity or a transection injury, again, I think that this really needs to depend on your physical exam. So if you saw the nerve intraoperatively, you know you didn't cut it. You bump it up into, you know, these earlier, like a neuropraxic or a third degree type injury. If you did see the nerve, if you're worried that you cut it, that would be something that you may just say, I'm worried enough about this patient. I think that we should take them to the operating room for an exploration. If you don't want to do that, you really want to get an electrodiagnostic study, you can get one in the first 7 to 10 days. And the things that you're going to look for on those studies is going to be that you don't have any of this compound muscle action potential or sensory action potentials, and you have a complete conduction block. And that would tell you that you've got a transected nerve. So how about nerve repair? We've got a lot of tools in our toolbox for nerve repair. I think that the non-operative stuff cannot be emphasized enough. So non-operative stuff includes therapy and desensitization. So if you've got a patient who you think has a sensory nerve issue, therapy. Just because hand therapy is called hand therapy doesn't mean they can't do desensitization for other patients. Supportive splinting can be really helpful. So if you have a patient who has a radial nerve injury, you really want to make sure you're supporting the wrist as well as the MP joints, because if those get tight, you really lose your ability to do a tendon transfer. One of the primary things you need for nerve and tendon transfers is that you have supple joints. And then nerve glides can be helpful as well. In terms of our surgical options, it totally depends on the type of nerve injury, but we have things like neurolysis, decompression, transposition, primary repair, and then various reconstructive options, which we're going to go through. Okay, so starting with nerve repair, we're going to have 2 big groups. We're going to talk about nerve repair, and then we're going to talk about nerve reconstruction. Nerve repair is where you take 2 ends of nerve and you put it together. Primary repair, which is where you put those 2 ends together, is the gold standard. If you can repair a nerve end to end, that's what you should be doing. The issue is you have to be in a tension-free environment. There are studies that look at the amount of tension time in a nerve repair. 8% elongation can decrease the perfusion to nerve by up to 46%. And then you can get a neuromotor continuity, or you just don't get any recovery across your nerve. The things that you need in order to do primary nerve repair are clean, stable wound bed, no infection, stable skeletal fixation. You obviously don't want to be doing a fine nerve repair when you've got no skeletal fixation, and then a good soft tissue envelope. And you need to do that repair as soon as possible. So like I talked about, reintegrating those motor plates, particularly when you have high nerve injuries, can be really important. And the other thing that is really important to stress is you have to do a really good microsurgical repair. So doing this is just an epidural repair, trimming back to good fascicles, not bunching your repair is really important, not taking bites of the fascicles. So you want to do this under the microscope. Just a trip down memory lane. Remember I said you have to match up the motor and sensory fascicles. If not, you get too much crossover and you won't get an optimal outcome. One of the things that you can do to help you with that is each nerve has a vena comitatus, which is this little vascular stripe that you can see on big peripheral nerves, and you can match those up, but also, again, understanding the topography of the particular nerve, which both the upper and lower extremity have, is important. Zone of injury. So let's say you put two nerve ends back together, high five, nerve repair looks good, but you didn't get out of the zone of injury. So the nerve is injured on either end that you repaired. That nerve is going to look like this. It's going to get fibrous, it's going to form a neuroma, it's not going to heal, and you set yourself back. So what you really want to do is you want to cut back the nerve to healthy budding fascicles. And you want them to look like this. You want them to be able to sort of be pushing out the end, and when you pick up the epidurium, the fascicles should move within themselves. And then the other thing you can do if you're cutting back a neuroma is you can feel it. So a healthy nerve should be soft and not firm. So we do this sort of bread loafing procedure where we cut proximal, cut distal, we pick up the nerve and we look at it head on and we say, does this look healthy? Are the fascicles budding? And that's important because you have really disorganized tissue in between. So you really want to have nice fascicles on either side. So nerve reconstruction. So that's nerve repair, nerve reconstruction. When it comes to nerve reconstruction, what we do totally depends on what the nerve injury is. And every nerve injury is a different flavor. One of the primary things that we consider is what is the length of our defect. And is this a pure sensory nerve? Is this a mixed motor nerve? Or is this a pure motor nerve? We think about what is the severity of the injury. Again, what does our wound bed look like and what are patient characteristics? And we have three main things that sort of fall into this nerve reconstruction. We have conduits, which is sort of a connector. We have acellular nerve allografts, and we have autograft. So when we look at the size of the defect, when you have a very small defect, so up to about 1/2 centimeter, you can do a primary repair. But once you get anything bigger than that, then you want to be thinking about doing some sort of graft. When you have a defect up to a 1.5 centimeters, that's where we employ conduits, where we say we can just have this polyglycolic acid little conduit that's going to help the axons find themselves. When you get to larger nerve gaps, you start to think about allograft and autograft. And really, I think the literature would support that if you're getting beyond 5 centimeters, allograft is no longer an option, and really you should be looking at autograft. So autograft is our gold standard. Similar to primary repair, we can do primary repair, which is our gold standard. Then the next thing we do is autograft. And the indications for autograft are, again, essentially any nerve laceration greater than 1/2 centimeter. But really, I use autograft in the setting of mixed motor nerves and important sensory nerves, because I think that autograft is more similar. It's your own nerve, so it's immunologically inert. It has all of those glial cells and supportive neurotrophic factors to be able to allow for regeneration. But there's no real consensus on what is the length of autograft I can use and still expect good outcomes. There's some literature that would say there's variable outcomes when we get up to even 20 centimeters. However, I think as a community, we probably reasonably agree that less than 6 centimeters, you can expect a reasonable outcome. Once you start to get bigger than that, it can be pretty problematic. The disadvantage is that there's a donor site. So you're taking this from somewhere else, and donor sites are limited. You have your sural nerve, you have your LABC, you have your MABC, different sensory nerves around your body in the upper and lower extremities, and patients do have problems with harvesting those sites. So let's go through a couple of examples where we would use an autograft. So this is a 40-year-old male who came in with a traumatic laceration to the dorsal arm. You can see here in the x-ray, we've got good bony stability, but we've got a large laceration. When you start to explore this, we found that the PIN nerve was injured, and then one of the superficial branches of the LABC was cut at the distal end of this laceration. When we looked at our gap length, we see we can't bring these ends of the PIN together to this end of the PIN. Since we already had some LABC here, we just stole a section of the LABC in the area of the field where it was already injured, and then we did a fascicular repair for the PIN nerve. Again, autograft motor nerve, important to use autograft. Here's another example, our classic 2 a.m. consult, somebody punching through a glass wall. These ones actually don't present for 2 days. And then you get to bed and their nerves have retracted into their swollen forearm. You can't bring the median and the ulnar nerve ends back together for a primary repair. So this is a patient where I think I've got 2 mixed motor sensory nerves. I've got large diameter nerves and it's in the proximal forearm. I still have a lot of innervation to go. So this is a patient that we take the sterile nerve for. So essentially we cable graft the median and the ulnar nerve, and then we do some RPNI at our donor sites here, and then we make sure that we put the nerves in under no tension so that we can rehabilitate the joints. Another example, again, my area of interest in pediatric or brachial plexus birth injury. So this is the classic Erb's palsy, which is C5-6 injury. These patients, if they're not getting good elbow flexion recovery by about 6 months, we know that microsurgical reconstruction does better than just watching these patients evolve over time. So we explore the brachial plexus, we isolate our nerve roots, we isolate our division, and we see that we do intraoperative electrical stimulation. We see that there's no conduction across this big neuroma. So what do? We resect the neuroma. We typically will harvest both sterile nerves, and then we'll plug them into the defect. Okay, so I want to re-mention donor site morbidity because I think that this is important. So again, autografts are in limited supply. Sterile, which is one of the best because of the number of axons that it has, because of the length that you can harvest, is nice, but you have a large area of the posterior calf where you have a dense anesthesia. This was a nice paper just that kind of looked at patients who had a major peripheral nerve injury and had sterile autograft harvested. And it said, you know, what are the symptoms these patients have? What is the morbidity of this procedure? And found that the large area of anesthesia shrinks over time. So significantly, that area will shrink because you get axonal sprouting. A reasonable number of these patients early on will have allodynia, neuroma type pain, and cold intolerance. But long term, when you ask these patients whether or not they would have the same procedure done again, a majority of them would say yes. All right, so acellular allografts. If we can't do an autograft because it's a limited supply, we may do an allograft. There's also some other indications where we might use this. So an acellular allograft is a cadaver nerve that has been washed of all of its immunologic type cells, and it just contains extracellular matrix, so it's sort of like a scaffold. I compare this to like bone graft that we use. So it's like a scaffold for the axons to be able to have a roadmap for regeneration. These are nice for short nerve gaps. I think that these probably are best for small diameter sensory nerves, such as the digital nerves. But people are really pushing the envelope for when do you use allografts? Can we use them in mixed motor nerves or not? And can you use them in long gaps? But I think in my practice, these are something that I would use quite readily for a sensory nerve that has, you know, 1.5 or 2 centimeter defect, and I don't repair that. I don't want to repair that under tension. I've got a tendon injury that I need to rehab and things like that. These can also be helpful for neuroma management. I'll show you a picture of that later, where you resect a neuroma and then we put an allograft in. The trade-off is these are expensive. So these cost a lot of money. I guess you can balance that with, is some of that cost offset by the amount of operative time it takes to harvest an autograft? And then allografts, I would say, if I'm using an allograft, particularly for a digital nerve, I prefer those over conduits. So conduits are polybicolic acid sort of connectors. So these were brought about in the 1980s, and basically you put them on short nerve gaps, less than 1.5 centimeters, and you ask the axons to grow towards each other. These, I think, overall just are limited in kind of what you can use them for. It really needs to be a small nerve gap, it needs to be a sensory nerve, and we just don't have the perfect indication for them. The nice thing about conduits, though, is they're cheaper than allografts. So if you do have a really small nerve gap sensory nerve, then you may consider using this. There is some comparative literature that would say that allografts in general outperform conduits for sensory nerves, and that's sort of pushed me in particular to do reconstructions with that and sensory nerves. So how do you rehab a nerve? Totally depends on the location, what your soft tissue envelope is, and what your other injuries are. But we like to immobilize these for a little bit of time, so 2 to 3 weeks, and then you start some desensitization, you start some nerve glides, and then if you're doing a motor nerve, I think it's really important to start to activate, have the patient try to activate those motor areas, because there's some literature to support that activating those motor areas either with the patient actively doing it or with electrical stimulation improves outcomes of repair of these nerves. So when we look at how do patients do after we repair peripheral nerves, this is kind of dismal. This is why we have so many people trying to work on better options for this. This is one of the largest studies that looks at using allograft for repair of sensory mixed motor nerves. And it's an industry-sponsored study, and it compares it to a lot of our historic norms. And I think if you start to break this study down and you look at the way that they analyze their data, you could probably analyze their data in a million different ways and get a couple of different answers. But I think the things that are probably worth taking from this paper is that small sensory gaps with peripheral nerve allograft work quite well. And I think that those perform essentially just as good as an autograft. So in my practice, instead of coming up here and having another donor site to plug into a sensory nerve, I typically will use an allograft if it's a short enough nerve gap. The other thing I think, maybe not quoting this number, but is a concept that is probably accurate, is that as you get really good or really long gap sizes, allografts don't work quite as well. And if we break down some of their tables, we look at what is our reference data. So how do peripheral nerve repairs do in general? If you look at digital sensory nerves with autograft, we get about 70 to 90% meaningful recovery. So that's an S3 or above. If you start to look at, and then you can compare that to 84% in the allograft group. If you start to look at motor nerves, they just don't do well. So upper extremity motor nerves, even when you autograft them, you give them the gold standard, 67% of those are getting an M3 and above. In the lower extremity, the data is so much more variable. So depending on what case series you're looking at, and I think it's kind of hard to synthesize these injuries because every peripheral nerve injury is different. It's a different level, it's a different type of energy, it's a different mechanism. So because reconstruction is not so hot, our world says, okay, what do we do next? How do we try to get these patients to have better outcomes? And that's where nerve transfers and tendon transfers come into play. So nerve transfers are indicated in patients that have brachial plexus injuries, those that have long distances to a motor implant, like I talked to you about, a high ulnar nerve transection, a high sciatic nerve injury. You can consider those two things. People who come in delayed, so somebody doesn't come in for 3 or 6 months with their nerve injury, and now you're like, okay, we're already 3-6 months behind. Or those who have a poor wound bed. So say you've got terrible scarring, not good tissue in a particular area, you may consider nerve transfers instead. And what this requires is an expendable donor. The nice thing about our extremities is they're redundant tendons and there's redundant nerves. So we've got multiple things that can do the same function. But there's really no definitive guideline for this. And you have to really tailor your approach for nerve transfers to the particular patient, their particular injury. And early referral is imperative. So if you're thinking a patient could benefit from a nerve transfer, this is one of those things you want to get the patient in early for. Our classic, probably most well-studied nerve transfer in the upper extremity is the Oberlin transfer, which is indicated in patients with C5-6 brachial plexus palsies. And essentially what you do is you take a redundant FCU fascicle and then you plug it into the biceps branch to reestablish elbow flexion. You can do a double testicular transfer, which has been shown by McKinnon et al. To do much better than a single testicular transfer. And that's where you add a redundant median motor branch to the brachialis. And then this is probably the most common nerve transfer that I would do in my practice, which is an AIN to ulnar motor. So if you have a high ulnar nerve injury, I mentioned this previously, it takes a really long time to get regeneration to your intrinsics of your pant. So what an AIN transfer does is you take it where it enters the pronator distally, and then you swing it over and you plug it inside into your motor fascicle here so that you can reinnervate the motor in place quick enough. But people are using nerve transfers for all sorts of different things. Okay, tendon transfers. So tendon transfers have been around for a long time. They're fairly reliable. And essentially your approach to that is you say, what is out? What do I need? And what is expendable? The requirements are that you have supple joints, that you have good soft tissue equilibrium, that you're asking one tendon to do one function, it's in the same phase, and that you've got healed fractures. And the nice thing about tendon transfers is they're not time dependent. So if you have a radial nerve palsy, you feel much more comfortable waiting to watch that patient recover from a nerve perspective because you know I have really good tendon transfers for that particular nerve palsy, and radial nerve palsy is kind of our poster child for nerve transfers. So again, they're not time sensitive, and timing depends on the level of injury. So nerves recover 1 millimeter per day or an inch per month. You kind of visualize what your level of nerve injury is, and you say, okay, I should expect that I have recovery to these muscle bellies at this time. And if you're not getting good recovery based on your clinical exam, you can also get electrodiagnostic studies to prove that, and then you can decide whether or not it's a good time for a tendon transfer. And we've got good tendon transfers for the upper extremity, and I think that the lower extremity data has lagged behind both the nerve transfer and tendon transfers, but there's quite a bit of literature coming through on that as well. Okay, so let's summarize. So we went from primary repair, gold standard, you do it in a tension-free environment, it's free. That's ideal if you can. If you can't, you've got multiple reconstructive options. Starting with small gap links, you can use a conduit, but it's a little bit expensive. Longer gap links, avoiding a donor site morbidity, and allograft is a good example, is a good option, particularly for sensory nerves. And then autograft is our gold standard. Nerve transfers and tendon transfers, if you have higher, more significant nerve injuries that you think that can benefit from those. So that's all of these on the left-hand side. And then I'm going to go just briefly through what our options are for neuroma management, because if you've got a sensory nerve neuroma, or you have a patient who had a traumatic amputation and they're painful from that, you should at least have an idea in your mind about how we treat these things. We've got a couple of options. I would say the first option would be in sensory nerves, small caliber nerves, digital nerves. You can use an allograft or an autograft to plug that in. So for example, back to that patient that Dr. Hughes operated on, unfortunately they got a little sensory neuroma in the dorsal sensory nerve. So you go in, you find the neuroma, and if you've got a distal nerve and you've got a proximal nerve and you've got an area between that doesn't look good, what you can do is you can just take that out and you can put a nice redundant allograft or autograft in that area. The other thing that is popular, and I think one of our residents gave a talk on last year, is targeted muscle reinnervation. So this was a concept that was originally described for powering myoelectric prosthetics. And has been shown to do quite well in optimizing prosthetics. Now we're starting to use it in neuroma management, phantom limb pain, and prophylactically traumatic amputations. And essentially what this involves is some microsurgical reinnervation of a non-functional muscle or a redundant nerve. So you take a nerve that has a neuroma and you plug it into a nearby motor nerve. So for example, the sensory nerve, you plug it into the motor nerve, and then you see it gets reinnervation. Essentially what these options have in sort of this neuroma category that I'm talking to you about is you give the axon something to do. So historically, when I was a resident, there was an OID question that was like, here's a painful neuroma, what do you do with it? And the answer to the question was buried in the bone. And Graham and I got made fun of for picking that answer, but it was actually right. Now we have better options. The other thing that we sometimes will do for neuromas is regenerative peripheral nerve interfaces. So essentially what that is you take a painful sensory neuroma. So this was a guy we operated on that had compartment releases, had a superficial perineal nerve neuroma. You take it and you suture the epineurum into the epimysium of the muscle, and then you essentially create a little muscle taco. You have to have good microsurgical technique for this, but overall it's not a brainiac thing to do. And essentially what you do is you give those axons somewhere to be safe. And this has been shown also to decrease phantom limb pain, neuroma formation, and is used in traumatic amputations. This is another example where that's quite nice, where you, this was a revision case that came in that had the radial sensory that was cut and buried into an LRTI capsular repair. had continued pain, and so they did a small RPNI and then buried it dorsally in the back. And I just want to mention that I think that this is important for anybody who does amputations. And the reason why is because we now have really good literature from multiple good journals that says that this decreases phantom limb pain and neuroma pain. And I think is starting to move towards a standard of care for patients when they're getting their acute amputation. And we know that the patients who get it acutely do better than the patients who wait to get a neuroma and then do that as sort of a salvage procedure. So what are the future aims of peripheral nerve surgery? Because we don't have, like, remember I showed you the motor, when you repair a motor nerve, the best we can get with autograft, which is our gold standard, is 60 to 70% M3 meaningful recovery. So a lot of people are looking at what else do we have to look at. So there are some molecular therapies that people are looking at to be able to augment polarity degeneration. Can we make that process a little bit more optimal for the nerve after injury? People are looking at electrical stimulation and gene therapy electrical stimulation. There's a big study by Susan McKinnon and JBJS last year that's sort of setting the stage for a mouse model for that, but people are also using that in individuals as well. I will do that depending on the situation. I'll use a checkpoint nerve stimulator, stimulate the nerve. And the reason that's helpful is because it's been shown to increase axonal regeneration in neurotrophic factors across the nerve. And then people are looking at other ways that we can repair nerves. So these sort of peg fusion, or can we use some sort of substance to repair the nerve better than what we can do with the traditional suture coaptations. So in summary, I hope that I've convinced you that this is an issue that can affect all of us, that it's really important to understand the type of nerve injury and the severity, and early referral is helpful. So if you have a lower extremity neuroma issue or you suspect a nerve injury, that's what we as hand surgeons are here for, because we like nerve surgery, we do nerve stuff. So you can always call us, we can talk through electrodiagnostic studies, we can see your patients with neuroma pain, things like that. I hope that I've shown you that we have a very broad way of treating these, from primary repair to reconstruction options, and even some of our reconstruction options have not traditionally shown good results. And so we're trying to push the envelope of saying, can we use neurotransfers, can we use other adjunct therapies to be able to improve this? Early referral and therapy is important. You've got to keep the joints moving. If you want to have a salvage procedure, you've got to have a supple joint. If you want to do a shim and transfer, the wrist needs to move low. And then I think that there's a lot of, like I said at the very beginning of my presentation, there's a lot of room for growth. We've started to understand a lot about the way nerves function, nerves repair, and regenerate, but we still have a lot of work to do. And with that, I will take questions. Jones.
So this is the great talk. There's so much information, and like so many parts of orthopedics, we're just rife with classifications and all these sort of detailed ways of breaking it down. And you can imagine that some neurologists in the 70s sort of got really excited about this and just sort of started making all these classifications. Any of those detailed classifications have any real data associated with it? Like this is a problem throughout our field, but this is one of these where it's like, these are hard. I mean, they're talking about descriptive histology, but have they done that on like 5 mice, or have they done that on like hundreds of patients?
Yeah.
What kind of data is actually there?
That's a good question. I would say probably I can't quote like a specific study for you. A lot of stuff in the nerve world is in animal models, and that's a lot of mice models. And the issue with that, probably with any field, is clinical translation. We have lots of things that say, we can see this happen in a mouse model, but it's not doing the same thing when we see this sort of allograft or whatever in a human. I think the thing that you can probably lay your hat on that we have used for a really long time is the Sutherland classification, where you're saying how severe is a nerve injury, what are the clinical findings I can correlate, and what are the neurodiagnostic findings? And then that can sort of help guide you of like, is this an early nerve injury? Is this a late injury? What I will say about things like TMR and RPNI, We don't have any animal studies of that because you can't like open somebody back up, transect the nerve, put it under histology and say, oh yeah, this is working. This is like reinnervating the axon straight here. We have some mice data to support both of those things. But yeah, I think it's hard. I think the big thing I would say is being able to classify your nerve injury is probably the most helpful, and that classification has been dependable over time.
So 7 Sunderland World War II stuff, actually. So just to put it in perspective. And that's the classification you just showed, 1 through 5. So it's been, and it's clinically based, actually, it was clinically based. I think you should study, somebody should study RPNI versus TMR.
Yeah, I told Nick that too.
Maybe you should do it, because prospectively, just, you know, I know that I think the trauma guys do RPNI, and then Dave Rothberg does it, and Casper is like TMR, I believe, for most things, and all of us do some of this at some level. Why not study prospectively and at 6 months know whether they have neuromas or not? You know, they have neuronal pain or not. It's just pretty simple. If RPNI is as good as target motor reinnervation, why would anybody do target motor reinnervation?
I completely agree, and I'm probably more on the RPNI side just because it's more simple. And Nick and I have talked about doing that study because that's what we're missing in that world.
Yeah, it should include the whole department because these guys do a few a year, and trauma's doing a few.
Yeah.
And it should be perspective, and it's pretty simple to do. You know what nerve you did. Does it have a neuroma or not?
Yeah. The only other thing that I think will be helpful for that is Nick's qualitative study on TMR currently, which is essentially helping us to establish like our endpoint, I think, can be phantom limb pain and neuroma, but I also think having the sort of qualitative measures of how do we evaluate these patients best first established, and then also using that at the same time. But I totally agree, and RCT is what's missing in that world.
It'd be tricky because you gotta blind the people who are evaluating the patients to what they have.
I always operate blind.
There's so much bias.
No, you can make it a patient reported. You get rid of that. You know, that's easy.
Awesome. Thank you guys.